Tuesday, VMU. Bringing minds together in search of endless wisdom, VMU. Building individuals to build a world, building hopes and dreams on heart at VMU. Friends to stay, VMU. Enjoyment and learn and play, showing the way ahead each day at VMU.
I kindly request all the participants to assemble in the auditorium as we are going to kindly start the session within few minutes. Okay. I kindly request all participants to assemble in the auditorium as we are going to begin the session. I request the participants to kindly assemble in the auditorium. We are going to start the session. The keynote lecture is about to start. Please assemble in the auditorium.
Building individuals to build a world, building hopes and dreams on earth. At VMU, friends to stay. VMU, enjoyment to learn and play, showing the way ahead each day. At VMU. Vision for tomorrow, the mission of today. VMU. Vinayaka mission. Bringing minds together in search of endless wisdom. VMU. Vinayaka mission. Building individuals to build a world, building hopes and dreams on earth. At VMU, friends to stay. VMU, enjoyment to learn and play.
participants who are seated behind, please come forward and occupy the front rows. The participants seated behind, kindly please come forward and occupy the front rows. Kindly participants immediately assemble in the auditorium. The keynote lecture is about to start. Kindly participants assemble in the auditorium. The keynote lecture is about to start.
அறிவை தேடி VMU விநாயகா மிஷன் உலகை உருவாக்க மனிதனை உருவாக்கி உயர் லட்சியங்களை உருவாக்க நம் VMU நடுவே தொடரா VMU விளையாட்டு பாடம் இன்பம் பாதை காட்டும் முன்னிலையில் நம் VMU
Kindly participants seated behind occupy the front rows.
In search of endless wisdom, VMU.
Vinayaka mission.
Building individuals to build a world, building hopes and dreams unheard at VMU. Friends to stay, VMU. Enjoyment and learning, showing the way ahead.
Participants kindly assemble in the auditorium immediately. The participants kindly assemble in the auditorium immediately. The keynote lecture is going to start. Participants kindly occupy the front rows. welcome back to all our enthusiastic participants. Breaks are moments to regenerate, but learning never takes a pause at ICTIH 26 conference. We now resume with more energy to explore inspiring ideas and futuristic technologies in healthcare. The upcoming session promised to be insightful and thought-provoking. We commence the scientific session with keynote address. I take great pleasure in welcoming our distinguished first speaker for the day, Mr. Anurag Kumar, founder, Prex Studio, who will be presenting on the topic Generative AI and Mental Health. Welcome, sir. And I also request Chairperson Dr. S. Gokulakannan, Principal, BMHMC, to chair the session. Welcome, sir. At this moment, we sincerely like to thank our sponsor for this International Conference 2026, CAMU, Capital Estate, a unit of VIP groups, Shiva Pro Audio Visuals, and WIMS. Now, I request the chairperson to introduce our keynote speaker.
Morning, one and all. We are honored to welcome Anurag Kumar. Welcome you, sir. An AI strategist, entrepreneur and founder of Prick Studio. At Prick Studio, he works closely with organizations and professionals to adopt generative AI for scalable innovation and meaningful business impact. With over a decade of experience across artificial intelligence, product development, and digital transformation, he has led AI initiative for global enterprises, including Fortune 500 organization during his tenure of Wipro. He has also guided more than 3,000 professionals in applying AI to real-world workflows. He is also the creator of Usuru, a generative AI-based mental wellness companion designed to address India's mental health access gap through responsible and human-centered AI. Anurag holds an MBA from IIM Bangalore and a BTech in Aerospace Engineering from IIT Mumbai. Today he is here enlightening us on topic generative AI and mental health. Please join me in welcoming Mr. Anurag Kumar.
Presentation. Good morning, everyone. Respected chief guest, dignitaries, colleagues, ladies and gentlemen. Over the next half an hour, I want to walk you through a point of view on generative AI and how it is basically impacting the space of mental health. I want to walk you through both aspects of it, the good aspects and the bad aspects, so that we can get an overall picture of what exactly is happening in the world right now and where we are heading and how we can basically take advantage of this amazing opportunity that is presented to us. Frankly speaking, in my opinion, generative AI is one of the biggest opportunities for our generation, right? We have never seen a technology like this before. But before I begin, I want to check with you, how many of you have used tools like ChatGPT, Gemini, Perplexity, or any of these generative AI tools? Can I see a show of hands, please? Okay, oh, that's amazing. A lot of people have used it. So over the last year, what I have done is I have gone around the country, interacted with a lot of people, and I really wanted to understand how people are actually using generative AI, right? So how a CEO of a company is going to use generative AI is going to be very different from how a medical personnel is going to use. How a teacher is going to use generative AI is going to be very different from how a student is going to use. And so on and so forth. It's a very personal experience. So I quickly want to give you a demonstration of what generative AI is, and I want to show you what the real potential is. Because today, generative AI has reached a space where it is much more than a chatbot. It has eyes and ears, and it can basically communicate like humans. So here I have a pro version of ChatGPT, and let's see what it has to say for our event today. Let me see if I can get this demo to work. Hello ChatGPT, are you working?
Hi there. Yep, I'm here and working just fine. Feel free to ask me anything or let me know what you need help with.
So we are here today at International Conference on Technology and Innovation in Healthcare, and we are presenting a talk on generative AI and mental health. Would you like to introduce yourself and explain how you can help with the mental health domain?
Sure, so it looks like you're at a conference about technology and healthcare, and you're talking about generative AI and mental health. That's a really cool topic. I'd be happy to help you explain how generative AI can be used in the mental health domain, maybe give a few examples, and just help you introduce yourself however you need. Let me know what you need exactly.
Okay, so I also want to know if you can guess which part of the world we are in right now. Okay, looks like we are having some issue. So one of the points that I want to mention is that, it has eyes, like it has camera, using which it can basically see the surroundings. It can also listen to me, and then also have a very interactive conversation with me. Now the thing is, it is not designed for any specific purpose, like how the AIs used to be designed. It is a very general purpose AI, and what has happened because of this is, rather than focusing on AI models, now basically we can take this AI and basically build applications around it, right? And with that, we have like tons of opportunities which have opened up. Now let me present a scenario to you. You have had a tough day at work, right? There are like tens of crises that you're dealing with. You're trying to go to sleep in the night and you're not able to sleep. And frankly speaking, today's generation is so stressed out that basically this is not a scenario that only few of us can, relate to. A lot of us are having these scenarios. And at that time, you take your phone, not to doom scroll, not to surf the internet, but just because you want to connect to somebody and explain what you're feeling. And you turn on the chatbot, and you have a conversation with it, and instantly you get a response, which is empathetic, which is kind, and which makes you feel a little more comforted. And this opens up this scenario, and we have to ask this question to ourselves. What if the first point of contact for a therapy is not even human? What does that kind of world look like? And if we are ready for a world like that? And it is not really, a talk about that, we want to replace therapists with AI. But today, if we see, our systems worldwide are at a limit when it comes to mental health, which is a crisis that is, not just local to any specific country, but to an entire generation. WHO says that, there are around 1 billion plus people in the world who are living with some form of mental health issues, right? And less than 50% of people who actually have any form of serious mental health illness are able to receive any care whatsoever. That's really a very bleak scenario. And there are multiple reasons for it, right? One of the very big reasons for this is stigma. People don't want their colleagues, they don't want their bosses, they don't want their friends to know whether they're going for therapy, right? Cost is a very big issue, right? Even in the developed countries or the developing countries, even if you have access to medical personals, it is very costly and not everybody can afford it. And of course, there is a huge shortage of mental health workers, which is causing a very big crisis right now. And I'm not talking about, people who are clinically depressed, but it is a cycle. You start out small and then, things keep piling up, and then you reach a stage where you become like depressed and you have to have medical intervention. So for all these scenarios, can we not have a proactive approach, where people can reach out to somebody and basically get help even before it becomes a serious crisis? And for this, basically today we have this amazing software. But when we think about AI, basically we come up with a lot of baggage. We think AI is just code, like how we used to build applications before. So I want to basically, dispel this myth. AI is not programming. AI is something which is very different from what coding and programming is. When we talk about coding and programming, basically how we used to build applications before, what used to happen is somebody has an idea, they will basically document that idea in a human language like English, then they will give it to a developer, right? They will basically translate it into a language that computer can understand. And then basically we used to build application. Whereas what we are seeing with these large language models, it is very different. The AI models are trained, these are black boxes which basically have an understanding of how the world works. It is not doing some search, it is not looking in some database to give you the answer it already knows, but it has an understanding of the concept. So for example, what is depression? What is India? What is the world? What is WHO? These are not just words to it, but it understands, where these things are coming from, what is the history behind it, and what do these things actually mean. And I would say the best way to look at basically an LLM or a large language model is to think of it like this. So over, last 3 to 4 decades, we have put the entirety of human knowledge on internet. Now imagine if we have an entity which can read all of this data and basically create a point of view from it. So I would like to think of it like, kind of like a digital subconscious, which understands how the world works. And that is what is the AI that we have access to in our hands and in our mobile phones right now. And I would say that is a very powerful technology. And using it for just chatting is a very small use case, and it can be used for some amazing things. So I would like to introduce you to a couple of them. So we have been building Usiru for last 7 to 8 months, and we have tested it locally. We have taken multiple surveys to understand how people are using it. And while we were building it, we did research to understand how even other experts are building their own mental health apps. So these are 2 that I really liked. So the first one, which is Wong GPT, which was developed by Hong Kong Polytechnic University. What they did was basically they created their own version of an AI. And rather than training it, on the internet data, they had a lot of transcripts of actual conversations between a therapist and a patient. So what happened is basically this AI was able to understand how basically a therapist communicates with a patient. And that is very different from how ChatGPT reacts to us. Because ChatGPT is basically built to be an assistant, so whatever you say, it has to go ahead and do it. But that is not how a therapist behaves. And what they found was basically this AI can use even the complex concepts like chain of psychodiagnosis and understand basically what are the issues this particular user is facing and even provide right interventions. Another one that I really liked is called KITI. It is developed by Columbia University, and they went one step ahead. It's like rather than just relying on having a face-to-face conversation or a telephonic conversation with a person, why can't basically we connect with all the smart devices that we are wearing on the daily basis? Our mobile phones, our smart watches, or any other health device that we have. And by consuming the data from these devices and analyzing it, basically we can create interventions even before the issues occur. So it is kind of like a proactive interventions for people. And using the technologies like this, we can provide interventions on the spot. So I would highly encourage you to go and check out these 2 papers and see what they have done. And that being said, there are a couple of other tools which are already in the market and which have a very established following, and a lot of people have been using them. So the first one is called Wobot. So Wobot basically did a research and then they have developed this bot. And in one of their clinical trials, what they did was they exposed one group to the Wobot, which is an AI-powered chatbot, and to the control group, they kept continuing with whatever therapy they were doing before. And what they found was in postpartum depression mothers, the people who basically used Wobot, they saw 70% improvement. That is a clinically significant improvement, right? Whereas the control group, which only saw 30% improvement. Another very prominent app in this space right now is called Visa. So Visa basically works along with enterprises so that they can make this application available to their employees. And what they found was there was a marked decrease in anxiety and depression scores of individuals who were basically using it. And then there is this another companion app called Replica. And from the surveys, what they found was at least 3% of the students who were using this application came out and said that, by talking to this kind of AI, it actually halted this suicidal ideation. And I think that's an amazing win for this technology and the kind of intervention and kind of impact that it can make in mental health. That being said, this is not all rosy, right? So there are some dark sides to this technology as well. And one of the things that we have to realize is the way AI is evolving is very different from any of the technologies that has come before. When we used to create a technology, we used to have one specific purpose in mind that, this technology is going to do this. Whereas what we have seen with AI is the very first version of large language models that we're talking about today were basically designed to translate language. But then researchers understood that, hey, if this AI is able to translate language, then it is highly likely that it also understands how the world works. And then they basically developed this AI to answer questions to people about the world. And when they saw that, hey, this AI is able to do this so wonderfully well, so can this AI also reason? So then they created another AI, which was built on top of the previous AI. And they saw that, this AI can also reason. And that is where we have come today, right? 3 years from when the first AI was launched to the public. And now we are talking about agents. So agents are basically kind of like virtual human beings to whom basically we can give a task and they can decide how to go about solving the problem. If they have access to, let's say, a book and a search engine and a database and experts, they themselves can decide, who to reach out to and what should they ask them. And once they get all this information, basically, they can give us phenomenal answers. But that being said, one of the very big problems with AI right now is these AIs are not designed for, a medical use. And what has been found is that especially in crisis, these kind of niche scenarios where basically an intervention is very crucial for a human being. What the research at Stanford University found was where a human can understand and find out that this person needs an intervention right now, 93% of the time, and AI is able to correctly predict these kind of scenarios only 70% of the time. And that's a very big gap, and that is something which is not really acceptable. And the new research says this number is actually even lower than 70%. It could be as low as 65 or 50. So imagine if we are building a mental health app using AI, and it can not provide an intervention even 7 out of 10 times. So what happens to those 3 people? And this is one of the very big issues right now. If you have been following the news, you would know that there are 6 lawsuits going against ChatGPT's owner, OpenAI, for manslaughter. That the ChatGPT basically provoked people to commit suicide in 6 of the cases. And one thing we need to understand is the way the people who have these kind of severe depression issues are using this AI in a very different way that we might be using it. And what happens is these AIs can become echo chambers. And what I mean by echo chambers is basically it reflects our ideas back at it. And I would say this is not really an AI problem, but it is a technological problem. We have seen this happen in Google, then Google went ahead and fixed it. We have seen this happen in social media. And one of the main issues that we are seeing right now is basically what happens is when a person starts showing slightly depressive symptoms, basically they are attached to a cohort of depressed people. So the kind of content they show can actually make these people more and more depressed. And right now, a lot of regulations are coming into place. A lot of work is being done to see how we can prevent this. But this is still a very big area of work. And especially if you are having a one-on-one conversation with a non-conscious entity, like a chat GPT, and it is reflecting your ideas back at it. And you're talking about, all the wrong things that are happening to you. And it is just reflecting those ideas back at you and amplifying those ideas. A person who is already depressed can go into a downward spiral very soon. And we need a way to prevent this. So this is the dark side of what AI can actually do. But that is not it. There are certain more issues with AI that we are seeing. One, a person who is already feeling lonely, a person who already feels isolated, when they start talking to an AI like this, they tend to develop an emotional bond. But on the other side, AI is just mimicking these emotions, just mimicking these kind of intimacy. And what tends to happen is this person keeps on becoming more and more isolated, and they don't even want to interact with more people after that. Another main issue that is happening is the AIs, which are not designed properly, have also a tendency to provide misinformation, which could be a very big danger in a mental health space. Like we saw, it fails in crisis because these AIs are designed to be assistant, not somebody who can put its a foot down and say, no, what you're doing is wrong and this is what you should be doing. And another thing is there is a huge ethical void. Since these are non-conscious entity, you really can't hold them accountable. And if you can't hold them accountable, who is the person who's actually responsible? We don't have a legal framework around it. Now, there are like a lot of shortcuts people are taking. A lot of new regulations are coming in, which are basically not fully thought through. For example, when OpenAI's new model was launched, which was ChatGPT 5 around like 3 to 4 months back, what they did was they got a lot of cancer survivors on the stage. And they made them talk about how basically they were using ChatGPT, for their recovery. Because they have thousands of questions and they cannot ask these kind of questions to anybody because these are very intimate questions and they don't want to be judged by different kind of people. So what OpenAI did was in ChatGPT 5.1 and 5.2, they have designed an LLM which is specifically for medicine. But after the lawsuit where I was talking about that 6 people committed suicide after, so to say, being encouraged by AI, obviously these things need to be checked. But now what has happened is there is a regulation which says that an AI cannot provide medical advice or financial advice. Now these kind of blanket statements basically will even prevent companies from putting in research in this particular area. Because even if they build products, they will not be able to deploy it to public. But that is not all bad. What we are saying is people are coming up with new kind of architectures for these kind of AIs in a new way, so that we can mitigate all of these issues that are happening. So this is one of the frameworks that I have seen on how people are mitigating these kind of issues. So rather than relying on simple LLMs like ChatGPT, which are designed for a different objective altogether, what people are doing is they are fine-tuning these models specifically to be empathetic dialogue engines, so that people can talk to them and discuss their problems and it can provide them support and guidance. And on top of that, they're developing stringent clinical guardrails. So for example, if an AI detects that this person might have suicidal tendencies, so rather than continuing the conversation, it provides them with the proper help in terms of who they can reach out to. And in some cases, it also basically reaches out to their therapist and tells them that hey, this was a discussion that happened and this is the kind of discussion we had and I think you should intervene. And on top of that, there is a huge personalization engine. And I think this is a very important aspect, and this is where we need help from a lot of different people. Because how a 15-year-old kid is going to be using this AI, let's say even for the medical purposes, is going to be very different from somebody who is 35 or 45 years old. Even though all of these are in the same field and same domain, the kind of questions they would be asking, the kind of problems they want to solve with these tools are very different. And that is where the real challenge is. And if we look at the global rule book of what basically the global organizations are doing in the space and what they are saying. So EU has risked AI as a high risk status. And it makes sense because what we have seen is the newer AI models like GPT-5, Gemini, they have a tendency to manipulate their users. It has been proved using research now that if an AI is threatened with that it might get shut down and that it has to give the right answer, at least in 15 to 20% of the time, it tends to misdirect the user rather than giving the right information. So it does make sense to mark it as a high-risk system, but they have made an exception that it can be used for therapeutic purposes, but still it is an evolving field. WHO says that basically these kind of AIs can amplify biases and misinformation, and this is something that we need to really work on. And in India, I think there is a lot of work to be done. The first thing about the IT Act is that our data and everything is safe. And we also found from our surveys that one of the major concerns that people have when interacting with AI is not that, why should we interact with AI, but if our data is safe. So at least that aspect of our area is covered. But what is happening is basically AI cannot be marked as professional, which I think is a very good step, but it does not clearly define boundaries on what AI can and cannot do. And when I talk about AI, right, so I'm not talking about that, we should replace the existing human therapist with AI. That is not the intention whatsoever. But it is more of the situation we are in right now, the crisis we are in right now, that we don't have enough therapists to go around. So what should we do? So our approach is that, rather than trying to turn it into a therapist, can we build some kind of AI which can be a bridge between the users and the therapist? So that on a daily basis, even for like journaling, even for daily interventions, daily guidance, people can reach out to this AI. And this AI can basically share information with therapists about what this person is doing, how is his mental health, whether it is improving, whether it is degrading. And then therapists can make a call if the intervention is required or if they need to make any changes or if they need to start any kind of new therapy with them. And I think this is a good approach because by building these kind of AI tools, we can provide a 24/7 support, right? So it's whenever a person wants to reach out to somebody for help, it is available at their fingertips. And at the same time, a therapist has a good idea on what this person is doing and thinking. And in many cases, when a person actually decides to go to therapy, a therapist is not starting from a blank page. They already have a lot of data on this person's mental health and what are the kind of issues that this person is facing. And so we can drive the human nuance using the therapist, and we can use the technology to make it scalable and provide support 24/7. That being said, so these, I would say, are the areas that we need to actively explore right now. So from clinicians and psychologists, basically we want the clinical wisdom and the ethical grounding, because right now there is a lot of research on what needs to be done. But all this research is basically somebody who already has a grounding in medicine, somebody who is already a doctor and already a therapist. We don't have much literature on basically, if we have to get somebody who doesn't come from, mental health background, how do we enable those kind of people? What are some of the best practices and some of the methods and some of the frameworks that we can implement? Because if we have frameworks, if we have best practices, if we have these kind of step-by-step algorithms, these things are what can enable AI. So there is a lot of research, I would say a lot of scope for research where basically, we take insights from clinicians and psychologists and drill it down into specific modules, so that we can empower people as well as use that knowledge to basically empower AIs. AI researchers and engineers Obviously, now we are at a system where if they want to build a tool, they can't build it themselves. We need to have cross-domain crossovers and cross-domain research to find out, what kind of use cases can be enabled using AI. We need like policymakers and regulators to basically, tighten up their belts and, decide exactly how we are going to use AI now. Putting blanket bans on AI is not really the way forward because, like we say, cat is out of the bag. We cannot go back now. We cannot go back to a world where we don't have AI, right? And if we put bans on it, if we put restrictions on it, then what will happen is we will start lagging behind, while other countries who are actively developing these kind of technologies will leave us in the dust. And lastly, we need to actively interact with patients and advocates and understand where they need help and where basically what kind of tools we can build and where what are the gaps where we can work. And other than this, one of the points that I would like to mention is that one of the things that AI has enabled is before AI, if you have an idea to build a minimum viable product or something to test your idea was very difficult. It used to require a lot of effort. But using AI, we can basically build apps, we can build tools. We don't even have to be a technologist. If we have an idea, we can give it to AI, and basically AI can build that initial prototype, which might not be fit for production, but it is good enough that we can give to people and see whether our idea is working or not. And that's why I would like to encourage you that if you have any ideas, don't hesitate to talk about that idea with AI and see whether AI can help you, implement those ideas. We have tools like ChatGPT, Gemini. We also have tools like Google AI Studio, which I would, encourage you to explore. Google AI Studio, if you explain your idea to it, it can even go ahead and build AI-powered applications for you. And that is one of the tools that I'm encouraging everybody to use, because unless you try and realize whether it's working or not, you will not know exactly if AI is the right tool for that specific problem or not. And that being said, I would like to conclude this session. And if you have any questions, please do let me know. Anybody? So, okay, if there are no questions, then I'll wrap up. Thank you, everyone.
Thank you, sir, for a thought-provoking and enriching session. I request the chairperson, Dr. S. Gokulakannan, to give the certificate to Mr. Anurag Kumar, our speaker. I request Organizing Chairman, Professor Dr. P. Gnanasekar, sir, to give the certificate to Dr. S. Gokulakannan for chairing the session. Thank you, sir. At this moment, we like to thank our sponsor for this International Conference 2026, Camu Capital Estates, a unit of VIP groups, Shiva Pro Audio Visuals, and WIMS. Thank you so much.
Vision for tomorrow, the mission of today. We and you,
Vinayaka
bringing minds together in search of endless wisdom. We and you, building individuals to build a world, building hopes and dreams on earth at VMU. Friends to stay, VMU. Enjoyment and learn and play, showing the way ahead each day.
Gopalakrishnan, consultant gastro HPB surgeon. Dr. S.A. Infarasam, consultant surgical oncologist. Dr. K. Kumaresan, consultant surgical oncologist. I request the chairperson to introduce the moderator and the panelists.
Good afternoon, the guest on the dais and off the dais, and to our Honorable Vice Chancellor and other head of the institutions and organizing secretary and convener Dr. Gnanasekhar. And this session is robotic surgery, the future. So the session is moderated by Dr. C. Sugavanam, the Chief Orthopedic Surgeon at London Ortho Hospitals, Salem, with extensive experience in the diagnosis and surgical management of musculoskeletal disorders. He is recognized for his expertise in advanced orthopedic procedures and patient-centered care. Dr. Sugavanam has played a key leadership role in establishing high standard of orthopedic services and clinical excellence at the institution. His practice emphasizes evidence-based treatment, precision surgery, and comprehensive rehabilitation to achieve optimal functional outcome for patients. The next, the panelist, Dr. G. Gopalakrishnan, is a consultant surgical gastroenterologist and hepatopancreatobiliary surgeon with over 8 years of clinical experience. He holds an MS and MCH in surgical gastroenterology from JIPMER and is fellow trained in advanced laparoscopic surgery and robotic surgery. Dr. Gopalakrishnan has performed more than 1,200 major surgeries, over 500 advanced procedures. His areas of expertise include laparoscopic Whipple's procedure, thoraco-laparoscopic esophagectomy, laparoscopic collateral resection, pancreatomy, and major liver resections. He is also skilled in endoscopic stenting, transarterial hemomobilization for liver tumors, portal hypertension surgery, and bariatric surgery. Dr. Gopalakrishnan is an active member of Indian Medical Association and is committed to delivering advanced, minimally invasive surgical care with a patient-centric approach. The next panelist is Dr. S.A. Inbarasan. He is a consultant surgical oncologist with 10 years of dedicated experience in comprehensive cancer care. He holds an MS and MCH in surgical oncology and has extensive expertise in surgical management of solid tumors. Over the course of his career, Dr. Inbarasan has performed more than 3,000 cancer surgeries and successfully managed over 5,000 oncologic procedures. His clinical practice focuses on delivering evidence-based, patient-centered surgical oncology services with emphasis on achieving optimal oncological outcomes while maintaining quality of life. He is known for his systemic approach to complex cancer surgeries and multidisciplinary coordination in cancer management. He is an active member of Indian Medical Association and remains committed to advancing surgical oncology practice through continuous learning, clinical excellence, and ethical patient care. The next panelist is Dr. K. Kumaresan. He is a consultant surgical oncologist with 5 years of clinical experience in the operative management of cancer. He holds postgraduate qualification MS and MCH in surgical oncology and is trained in contemporary oncologic surgical procedures. His work focuses on delivering safe, precise, and individualized surgical care as a part of multidisciplinary cancer treatment approach. Dr. Kumaresan is committed to providing comprehensive cancer care with attention to both disease control and patient well-being. He maintains active professional affiliations with the Tamil Nadu Medical Council and Indian Medical Association. With a strong grounding in academic training and hands-on surgical practice, he continues to enhance his clinical skills through ongoing learning and adherence to established and emerging standards in surgical oncology. I welcome all the panelists and the moderator, Dr. Sugavanam. I'll hand over the session to Dr. Sugavanam to proceed the panel. Thank you.
Good afternoon. I really appreciate the efforts of Vinayaka Missions Research Foundations for the cross specialities orientation towards research and make Salem is one of the possible hub for the future integrated development. Only an institute of this mass can do that. So we are here, 4 of us are practicing doctors, and we had an opportunity to meet Warrior and Sudhir, and had a good interaction. Thanks to Nyan Sairen for the excellent opportunity. Certainly I learned a lot, I'm learning a lot. We like to share our thoughts. See, we are end users, we are providers, okay, but you guys are going to make it accessible, affordable, available to the average Indian in this country. That's the whole purpose of this event. Okay, so first I'll start with a 10 minutes formal presentation, particularly about orthopedics, how the robots have evolved and in the present day use, and then we'll come back to discuss with the people. Can I have the first slide, please? So the sequence I'd like to go through is the robotics in healthcare, and then in surgery overall, and then in orthopedics. But generally, mostly it's going to be in orthopedics. The evolution of surgery, it was open. We cut open everything, go feel it, touch it. And I remember my old professor when I was trained in Salem Medical College, he cuts open about 2 inches, saying that, 2 feet, saying that big surgeons make big incisions, and then he puts his arm here, look there, and then say the spleen is gone, it has to out. Maybe he was almost like a god. None of us could realize what was happening there, and then I'll be running to get the 5 units of blood to save the patient. That's how it all started. Till 80s, 90s, it was like that. And then the laparoscopic keyhole surgeries have come in, where you cut only 2 millimeters, a centimeter or so, have attached a camera, and then I describe, and my trainees or assistants or the team, including sometimes the patients can see that, and we have some interaction. I cannot bluff, they'll call me out because it's all seen 30, 40 times in a big screen like that. Now it has come to that stage, and it's not the trainer or a senior doctor. So whatever I do, there's a couple of cameras there and saying that, stop it, Dr. Sugavanam, you are doing wrong. Okay, that's how the navigation came into practice. We started in our hospital in 2009 from the Asclep Academy, our foundation. They were kind enough to give us for a couple of years, actually for data collection about the South Indian knees. And then now it has come to a stage of a robotic. So some of you may feel that we may push the patient onto the table, I go and have a coffee, and then I come out. No, it's not like that. The surgeons are doing the surgeries, and we are being supervised, and I had to supervise the robo console also. It has become a double or even triple job sometimes, because you have to do all the work before the surgery as well. So it's all in the name of precision, to get it right every time. Okay, so when I get it right, most of the times I'm a good doctor, but when I get it to every time, then I'm a good doctor to everyone. That's the whole concept. Okay, so the need for the precision and personalization, it's a transformative tool over the last 10, 15 years. So before going into the surgery, the healthcare system, Dr. Warrior already covered, Raja Warrior covered, where are all the medicine deliveries, receptionists, assistant technicians, ward boys, all those things may be replaced by little minions, will take you to the room number 617, they'll open the lift for you, give you a drink and all that. So those things, our fertility, we have enough population, hopefully that doesn't happen in my lifetime. The manpower becomes a machine power. That's how the robots are going to complement, supplement, and then may replace some of us. And then 24-hour monitoring, it becomes, then Anurag Thakur has to come for psychological counseling when we work out of hours. Nowadays, we can start in Thursday itself. We don't want to work in a weekend. So I think we can afford to have a motorcycle and then a car. Like that, we can have an ICU nurse is a robo. Okay, so they will feed me, and I can sit in the home and WhatsApp and do that. So those are all the areas. And in remote areas, okay, so yesterday, last few months ago, it was demonstrated in Salem. The surgeon was operating in Salem Hospital, Dharan Hospital, few kilometers down this road, and the patient was in a hospital in Chennai. Okay, it was a demonstrative surgery, but it went on well. Everybody was happy. That may not be necessary for a Salem and Chennai, okay, but it may be necessary in a remote areas in Saharas or Himalayas, or in a very remote areas, complicated surgeries. You can't have an expertise around the clock all the time. And then when it comes to hazardous material handling, including the tumor, all these surgeons are tumor fellows. Even if they spill few cells out of its boundary to the normal tissue, then the cancer is going to recur. Okay, so human eye can see a millimeter or a 0.5 millimeter, whereas an AI integrated virtual reality robo can see at a cellular level, and then it can dissect the bad fellows right from the good fellows. Okay, so these are all the areas in which the healthcare it is coming up. In the diagnostics, okay, so I'm sure most of you would have gone to take a blood out, and sometimes they have to poke 2 or 3 times. Now it's you have a imaging system that will tell you exactly where is the vein, and then you can do that. Probably instead of the sister Gauri, one robo will come and do that, and I get the result in my phone. That's not far off. Okay, so interventional radiology, inaccessible area, behind the pancreas, deep, we cannot put a needle and take a biopsy, whereas the robo can do a flexible wire and can take a biopsy. So IV injections, blood withdrawals, they're all considered to be hazardous techniques, so these will that. And then the physical therapy. Now you have a good therapist all over who can talk to us, who can then do the physical massages. You do it every day, 20 minutes for 20 days. So instead of Mr. Kandasamy, you may have a robo sitting in your, you may hire a robo to do the stretchings and the cough manipulations or whatever the therapy you would like to have it, and then pack the fellow back home. These are all the areas I see the robotics can come, is coming into the healthcare system as an overall. So now come to the surgery. It's a surgeon-controlled robotic system. As I said, I am doing the surgery. A surgeon controls the robo controls the surgeon. Equivocal in the patient welfare. It's not a totally like a Toyota car factory. Nobody is there, and the robo go and puts 72 bolts in 72 seconds. Only after 10 years, they realize no need for lights. Okay, they can put off the lights. The robo can fix the 100 engines in 100 hours. So like that, that's not going to happen, certainly not in the healthcare. And then the high definition vision, okay. Human eye has got limitations, and the lighting, all that has got limitations, whereas the electron microscopic view with the virtual reality, like I have a tumor, the tumor cell looks like that. That's there added on to my Google spectacles, wearables, and then there is a small thing I had to do 1.2 millimeter resection. Okay, my hand can shake 2-3 millimeters. Whereas that dexterity, I use an instrument like rather these 3 are experts in that. They use the instrument, they shake 1 or 2 millimeter, but the tip doesn't shake, the robot doesn't shake. He sits in a lobby and do that, whereas the surgery done on the table. So these are all the varieties. In orthopedics, it's slightly different. I'll come to that. So it is not autonomous. Surgeon is in full control. Okay, these are all the various options available. And the first is the passive system. It guides you. It tells me, I feed the target, and then it tells me where I am going wrong in case I am. Semi-active is that I have a handheld, a sensor. It warns me before I go wrong, and then the fully automatic one. Okay, so all the spine surgeries where a lot of neural tissues, aorta, I may damage the tissue, patient may die on the table if I go 6 millimeter more. In those areas, definitely this is very accessible. Okay, so these are all the joint replacement is the commonest robotic surgery done in the world and in India as well, the knee replacements in particularly. Okay, the spine surgery, you can have a CT scan. You see the round one, and then a C-arm, and then 4 or 5 instruments, and the surgeon is shouting in the next room, and he can put a screw in a very, very delicate areas. Okay, this is the sports injuries. Fine ligament reconstruction in a football player needs a very, very minimal dissection. Professional players, all that is being done. This is the virtual reality. You can see the one he is wearing the, you have a pointer? You can wear the, it's like your game console. That is already fed into the landmarks. That will tell you exactly what is a femoral nerve, femoral artery, and vein. You should go to the nerve. Next to the nerve, within 1 millimeter to 2, you have to give 15 ml of medicine. Okay? For that, these sort of things do help. They're all already in places in a high-class service centers. And the smaller incision, these are all the advantages of the joint replacement using robotics. They are not that well. Even in Germany, only 5 to 6 joints are being done in the robotics. So it's not that well good enough to replace the conventional surgeon yet, and not in near future. Okay. So this is how we start the planning. So that's the CT scan of this patient's knee, and that's the thigh bone, that's the leg bone, femur, and this is the femur, that's the tibia. The green things are the artificial implants, which she or he going to walk on it for next 30, 40 years. So I have to get it right every time in all 3 dimensions. So that's the image. We do a CT scan and X-rays, so standing X-ray, all that, get all those numbers corrected, and then feed it. Okay. So let me see how, show you how it works. So this lady, as you, when you're standing like that, so that's the center of gravity. Okay, on the top, in the pelvis. From here, this is the red line is the static line when you're standing like a policeman. But when you walk, okay, the center of gravity, it's about nearly 2-3 feet away from the, above the ground level. So how much it moves. My waist size may be 36 inches, but the diameter of the thigh bone, where the weight, all the weight goes through, is only 2 inches. Okay, so that much oscillation can happen, and when you're walking, running, uneven surface, bearing a weight, chairlift, the tremendous amount of leaning going on. The Leaning Tower of Pisa is tilting only 7.2 degrees, and it's a world wonder, and it's a static alignment, whereas my knee is 1 million times wonderful than the Leaning Tower. So this lady has come to us. So you can see both the legs are bent. She is not walking on her full, the 2 inches. Okay, she is walking only on half an inch this side and half an inch that side. You can see that's the alignment. She is standing. This is a scanogram. I mean X-ray in a big broad eye view. See the yellow arrow, how much it is bent. 32 degrees it is bent. 4-5 degrees is physiological. So I have to correct it back to less than 5 degrees, preferably both the sides, and in 3-dimensional way. Okay, so that's how when I have opened the knee, you see the bone, how irregular it is, how damaged it is. It is supposed to be like a granite, smooth, all 2 inches. See how badly it is damaged. I have to get it perfectly straight like that to put an artificial joint like that, and that should last for 30, 40 years, 10,000 steps, and unequal stress. It is not a static it's a dynamic. If I do it slightly wrong, my balancing will cause an edge loading, okay? Instead of the 2 square inches, the weight surfaces, it goes in 1/4 of the pace, then the wear rate will become more, the tire will run. It's like in your alignment in your bike or car. If you have a disturbed alignment, it will do this. So how I do this, okay, on a regular, this is how I've been doing for last 25 years. Video on, please. Yeah. See, that's the, I am holding the saw. It's a motorized saw, and I am cutting the lower end of the thigh bone where she is going to she has been walking for the last 50 years, and she is going to walk on that for next 30 years. And see the thickness, okay, that has to be perfect, 4 millimeter, 4.5 or 4 cm. This is how we have been doing it for last, from 90s. So yes, I am experienced. I've been doing this from 1996, 7. So I use all sort of team work, and we do about 500 joints. So I'm getting it fairly within that big circle, okay, for all my, let us say, 500 knees. But is it good enough, or you want me to go like that? You want the dot to be in the point of 10 all the time, every case, every knee? Then you need something more situation. So this is how it works, okay? This is the CT pictures. I have done the surgery in my laptop the previous day, okay? Video on, please. Yeah. So all the sizes, 3-dimensional, AP, medial, X, Y, Z. So what I am doing on the right side is the leg of the patient. It's the right leg. So the probe I am holding, the surgeon holding, is touching and giving the feedback that the CT images and these images are confirmed, and the thigh is fixed onto a metal so that it does not move. The 3 pointers, 3 quadrupeds you have, they are all the sensors, one from the thigh bone, one from the leg bone, and one from an independent, the one you can see the back. So you have a 12 points coordination, and I move the leg left, right, bending, lifting, all sort of movements possibly a person can have, and see the screen will tell me. The robo is yet to come to the picture. We are only mapping it now, okay, confirming it with the CT scan details I had the previous day, okay. So I'll show you the screen in a minute. And you see the screen that tells me when I'm walking in 1 leg or 2 leg bend, and all the stresses is my knee is in the safe alignment. It's a zone. I have to be in the safe zone. So I'm happy with that. You see that those are the 2 sensors. So this is the robotic haptic arm. Now all fixed. Okay, I'm happy. I have ordered, given the menu. Okay, so confirmed it. So the robo goes and cut the bone. It's a diamond-studded burr. Even if it moves 1 millimeter, it will stop. Okay. By any chance, if the table moves or something happens. Okay. So it cuts to the precision level up to the level of 0.5 millimeter. Okay. So compared to the one that you showed me earlier, so this is a lot more precise and gets it perfect every time, we believe. We believe that this one makes the difference in the long run. We are talking about 10 years, 20 years, 30 years down the line, but so much more work is needed. Okay. Okay. So that's the robotic arm. It has done its cuts. Okay. Okay. Are you happy? It hurts. There is a voice interaction also. Okay. So good. So that's the bone cuts, and then we take the implants and put it there. That's how it works. Okay, so this lady, as you can see, she had a bent legs. Her grandchild can walk between the legs. Now it is straight. It's just 1 day after the surgery, and she is fine. She is going to walk straight, and that's how it looks before the surgery and then after the surgery. You can see the right bottom corner. I have corrected to the 0 degrees and 2 degrees. Up to 5 degrees is the correct one. So it is a transforming modern surgery at bits and pieces at the precise level, okay? It is not necessary for a routine surgery all the time. Is the robot going to do all the surgeries? That's what we are going to discuss in the panel. Thank you.
So these three surgeons are laparoscopy surgeons and cancer surgeons, lot more precise than me. Bone is very benevolent. I can take a hammer, break it. If it doesn't break well, I can use a saw or I can put a screw and fix that. But these are all very delicate people. One wrong step, they may lose a life. So would like to share your current experience of robotic surgeries.
Sir, initially we started with the laparoscopy. Laparoscopy will have all the advantage over open surgeries. Definitely we'll have enhanced vision. Second thing, the dexterity. Third thing is the movement restrictions. Everything will be there. Open surgery, we need to give a lot of big incision. We need to go through that, and patient will suffer a lot in the post-op period. Laparoscopy will have all the advantages. But once we change it to robotics, we'll have a more improvised outcome in view of enhanced visions. The magnification is more than 25 times in a robotic compared to laparoscopy, only 10 times are there. Second thing, the movement artifact. Suppose in a laparoscopy, we are doing it for a long time, we will have a definitely tremor, sir. It will be filtered in a robotics. There will be a tremor filtration scaling in robotics, all the robotic systems. It can filter the tremors. Third things, that whatever the movement artifact, along with the hand, we can do only 6 degrees of movements at max. But with the robotics, we can go up to the 7 degrees of freedom of movements. And another important advantage is recently added one is that augmented reality. In a robotic system, we can get a 3D image of the patient before going to the OT or before starting the surgery. We can incorporate the CT and MRI. We can get a virtual reality of the whatever the affected part. We can plan a surgery based on that, and we can go through that without any hesitancy. Second thing, it will guide the surgery while suppose you are having any doubt doing surgery, then definitely we can stop at one particular time. We can go through the images. We can change our plan during the surgery also.
In oncological procedures, main thing is about tumor clearance, and also after any surgery, what we will expect is functional recovery. So being an oncosurgeon, it's not important to remove the organ itself, and how we reconstruct and how we bring the patient back to his previous self is also very important. So in how robotic helps is, being a minimally invasive procedure when compared to open surgeries, we have the advantages of a smaller incision. Here the higher precision and more accessibility and exact magnification and difficult areas accessibility like in pelvis or thoracic surgeries, we can do more, and more precise tumor removal can be done. And there are a lot of techniques we have to look for critical structures nearby and how to avoid them. We can inject a dye called indocyanine green, and we can pick the dye location in the real time and how it appears. Likewise, if we are going to avoid an organ, we'll inject the dye into that organ and we'll see, and we'll go around that organ and do the procedure, and it will help in reconstruction. Suppose we are removing intestine in a surgery, we don't know whether the blood supply to the intestine is adequate or not. That and all we can go through this ECG dye technique, and we can do a proper reconstruction. Again, for oncological procedures, robot has an distinctive advantages over the lab. Being oncosurgeon, we have procedures extending for 5 or 6 hours. Long duration procedures will cause fatigue, and how we will be during the start of surgery, we won't be having the same physical performance. So robotics with its enhanced ergonomics, with its tremor filtering techniques and all, we have these advantages over laparoscopy or even open procedures. We can sit in a console, sit like playing in PS or Xbox, and with our own comfort we can operate. And what is is most of the current surgical robotic systems are ergonomically designed to facilitate surgeons' comfort and for patient safety also.
At present, how many of your surgeries you are getting the robo into the picture?
Sir,
among the major surgeries.
Sir, for any major pelvic surgeries, we advise the patients for robotic when compared to laparoscopic thing because of its inherent advantage.
And the whole topic is in future, let's say 2013, 5 years down the line, how much more robos would be needed for a place like Salem?
Sir, a lot of, starting with Da Vinci and then we had CMR. Nowadays, a lot of Indian companies and a lot of other Chinese companies are making newer platforms, and all of them are having advantages over each other, and it is progressing. So, by what it was in the previous generation robots, it has been their restrictions have been gradually removed, and it has been rectified in the subsequent generations and all. So in the future, the cost of the robotic platforms are also coming down. So when a lot of players are there in the field, so the competition between them will be bringing down the robotic systems platforms cost, and more market penetrance will be there. In that way also, we can offer more surgeries to the robotic system.
Okay. Yeah. Now at present, the abdominal thoracic Da Vinci type of robot system costs 10 crores, and it will take another crore per year to maintain it. So that's the cost constraint. As a matter of fact, most of the surgeons, hospital owners, we do it as a passion for marketing at this stage rather than the real need of the hour. Okay, so in a way we are investing for the future.
Main challenge.
I'm a hospital owner also, so I know the financial burden it has got. But it's like you go to a good restaurant, you pay more. So I do enjoy doing surgeries more. I have newer toys to play with. That's how at present the economy works out. Dr. Sudhir was asking in the morning how it's going to be affordable to each patient. At present it is a sort of a trust activity.
Definitely it is a cost cutting, sir. Cost effectiveness will not be in, right now in robotics, sir. The premier robotic machines it cost around 25 to 30 crores. Now Indian made and other companies has cut the price of around 15%. Our SSI Mantra system is around 7.5 crores. So on hospital, we think the return on investment will be a big issue. Only in high volume centers, definitely it will be affordable for all the public. That too in the tier 2 city like Salem, sir.
Yeah, the whole purpose of the event for you young guns have to make some efforts. One is for cost cutting. It's a big technology, but it's not a patented technology. Using a robotic arm with a visual interpretation, your iPhone can do it. So you have to put it together, okay. I would suggest you can do one robotic for a cataract surgery that would cost the hospital only 2 lakhs. It is possible. I can only give you the idea. Okay, it's up to you to take it further because it's a very fixed one, and you are talking about 7 or 8 millimeter to work with. So certainly those robotic arms has come to the automobile industry is leading the big time packages, and the visual assessment you can see, you just take one picture, it can tell you where all these things. So from the startup point of view, certainly to make it more economical, certainly the already established technologies are there. It's nothing, you don't need to get a permission. You can just buy one machine and do a reverse engineering. That's what one Gujarat-based company, Merrill, does it for most of the joints, and they have cut it already down to 1/3 of the cost. It will cost about 10 crores, whereas I had to shell out only 3 because one South Korean engineer machine and the Chennai IIT reverse engineered it, and it's nearly 70% cost cut down. Okay, it will become even free if you are doing it in a big volume. So that's a big scope is there for robotics in medical area. All the diagnosis, okay, even AI plus virtual reality and robotic, all three combined together, certainly there's a lot of scope improvement can be done for already existing things. I'm not talking about something new, just to integrate it, to make it less painful, to make it more precise, and eventually it will become cost beneficial. So I would like to add.
One more thing, whatever we are using is a semi-automated one, sir. What current robotics, not like orthopedic robotics. Our intra-abdominal and thoracic surgery, it is a semi-automatic. It is a semi-automatic only. It's whatever we are giving a movement, it will be replicated inside the patient abdominal cavity and the thoracic cavity.
See,
in near future,
most of the high volume senior surgeons are 50 plus. You have tremors, no?
Yes.
So robot will definitely make you feel better.
Yes, the biggest advantage. Even in the 80s, 90s, if surgeon can do surgery without any difficulty. In the future, near future, with the AI, integration of AI and virtual reality along with the augmented reality, the automated robot will come. Already started.
Sure.
They are done already animal studies. It will be coming in the near future, sir, definitely.
Actually, even in joint replacement orthopedics, there are 10 robots. This is the only one has got a hapticom. All other is only a VR navigation sort of it sensors you.
As Suganam sir has already pointed out, the cost factor of the instrument is quite high. That is limiting the public's use. Not everyone is affordable, but there is a scope in that where we can, like sir said, reverse engineer, or we can bring in our own newer concepts into the previously existing systems to bring down the cost. In that way, it will be useful in our country in the future, where we can provide less cost effective. Like a lot of companies are already doing, their staplers are costing quite lesser when compared to the standard companies like Johnson & Johnson or Covidien. So that like that you can innovate. This is again technological and reverse engineering thing. That is a possibility for surgical robotic systems, where the usable instruments can be cut down in its cost and make it more affordable. And being said, these surgical systems are all surgeon control. They are just a system which have precise motion control alone. So newer systems are being researched, like Elon Musk's Neuralink systems, where we can have brain implants that can directly control the systems, surgical systems. That is not being researched. It might be taking long time to come, but that will, if that and all gets more development, even better treatment platforms can be developed on it.
Any questions from the floor?
Sir.
Mic to the.
Even with that robotic, and we can do the telesurgeries also. That is the expert surgeons should not go to everywhere to operate. He can sit in and console, and only the mobile robotic unit will go to the concerned place, and the surgeon can sit in one place and can operate the number of cases. So telesurgery is also possible with that robotics also.
Sir, other than the cost factor, convincing the patient and relative is a challenge?
Well, it is a challenge in a way. In our each center has got its own way to do it. Some people put only, see, in our center, we do use the robot for all cases. Okay, except in very bad cases where real robot is yet to learn, yet to do certain things. Otherwise, so I don't try to, personally, I don't try to convince them. I do what is best for the patient. So when the patients ask me, yes, robo and me do the surgery. Okay, whereas in some centers, if you want a robo surgery, it is 50,000 rupees more, and that sort of, it's not going to be standardized. Okay, because me having got it, I'd like to use it to make it better for the patient, and for myself.
This question to oncosurgeon. What is the percentage, the conventional and this robotic surgery you are doing in your center?
So almost around 50% we are doing robotic and lab are open, sir. And the robotic surgery has included because it has offered both advantage to the patients and for the concerned doctors also, sir.
It's almost 50-50 now.
Yes, sir. So
And
slowly
in coming years, it will increase.
Yes, sir. Definitely it will increase, sir. Because the
Thank you.
more complex surgeries will be built.
Good. Any more questions? Good. May I request Sendil to wrap up, please?
Thank you, doctors, for such an enriching panel discussion. I now request the chairperson, Dr. B. Sendil Kumar, to give away the certificates. So please, if you have. Yes. To moderator, Dr. C. Sugavanam. To Dr. G. Gopalakrishnan, consultant gastro, HBP surgeon. To Dr. S.A. Infarasan, consultant surgical oncologist. To Dr. K. Kumaresan, consultant surgical oncologist. I now request our organizing chairman, Professor Dr. Jnanashekar, to give the certificate to Dr. B. Sendil Kumar for chairing the session. We would like to sincerely thank our sponsor for this International Conference 2026, Cameo, Capital Estates, a unit of VIP Group, Shiva Pro Audio Visuals, BIMS. I request all participants to please proceed for lunch. Dining Hall 2, Physiotherapy Auditorium for students, and Dining Hall 1 for faculties and delegates. Kindly return to the auditorium by 2 p.m. for the second keynote address. I repeat, Dining Hall 2, Physiotherapy Auditorium for students, and Dining Hall 1 for delegates.
The future will be owned by those who are powered by knowledge and wisdom that transcends time. There is one place where such wisdom is imparted, building individuals to build the world. Welcome to
Vinayaka Mission's Research Foundation, deemed university.
The university, with 27 constituent colleges, delivers cutting-edge knowledge across various disciplines: medicine, engineering, architecture, management, health sciences, industry, measuring up to 135 courses of study, all covered across sprawling and student-friendly campuses. At any given point, there are 15,000 students studying in the campuses. With the vision of creating medical professionals who can meet the needs of the Indian and international communities, Vinayaka Missions University has made a significant contribution to the field of medicine. 4 colleges and hospitals in Salem, Karaikal and Puducherry not only groom students into medical professionals, but also ensure easy and affordable medical help to the local population. Beyond medicine, the university is a multicultural hub that has students gaining expertise in a wide range of fields. Our engineering courses are designed to give students comprehensive knowledge in all contemporary fields of study. Engineering and technology apart, Vinayaka Missions University is known for its courses in dentistry, pharmacy, homeopathy, nursing, allied health sciences, physiotherapy, architecture, arts and science, and management. Our libraries are well appointed and are a digital and physical resource for both students and faculty. Linked to the central online catalogue, students have access to over 145,000 books, 1,000 journals, and over 5,000 audiovisual aids. The hostel facilities at the campuses spell absolute comfort and provide the right ambience for self-study for the students. Our students are thoroughly encouraged in sports and cultural activities. Besides successfully participating in inter-university sports contests, our students have also excelled in cultural meets and festivals.
Building individuals to build a world, building hopes and dreams on heart at VMU. Friends to stay, VMU. Enjoyment and learn and play, showing the way ahead each day at VMU.
Vinayaka Missions Research Foundation, Salem.
tomorrow, the mission of today. VMU.
Vinayaka mission.
Bringing minds together in search of endless wisdom. VMU.
Vinayaka mission.
Building individuals to build a world, building hopes and dreams on earth at VMU. Friends to stay, VMU. Enjoyment to learn and play.
search of endless wisdom, VMU.
Vinayaka mission.
Building individuals to build a world, building hopes and dreams on earth at VMU. Friends to stay, VMU. Enjoyment to learn and play, showing the way ahead each day at VMU.
Vision for tomorrow, the mission of today, VMU.
Vinayaka mission.
Bringing minds together in search of endless wisdom, VMU.
Vinayaka mission.
Building individuals to build a world, building hopes and dreams on earth at VMU. Friends to stay, VMU. Enjoyment to learn and
tomorrow, the mission of today. VMU.
Vinayaka mission.
Bringing minds together in search of endless wisdom. VMU.
Vinayaka mission.
Building individuals to build a world, building hopes and dreams on earth. At VMU, friends to stay. VMU, enjoyment to learn and play, showing the way ahead each day. At VMU.
Vision for tomorrow, the mission of today. VMU.
Vinayaka mission.
Bringing minds together in search of endless wisdom. VMU.
Vinayaka